Good morning, everybody. Welcome to our part one of 3 parts to this course on best practices for managing perceptual impairments post-stroke. For those of you who don't know me, my name is Sue Briley. I'm the Regional Education Coordinator for the Northeastern Ontario Stroke Network, and we're excited to be putting on this course for you today. We are recording it and posting it to our YouTube channel so that if you miss parts of it, you'll be able to go and watch it there. We'd like some of you, if you can, keep cameras on. So our speaker has somebody to speak to. We're looking for a very interactive session, and Anita will speak about more of that to you once I introduce her. We will do an evaluation. It will be after part 3, and it'll be electronic as well. We will send out certificates after part 3, so you can expect those in your mailboxes. I'll take 1 minute to introduce Anita, and then we will move on as we have lots of information to cover in 2 hours. We had 61 register, so I'm thinking that a lot of people will be joining up as we get going today. So it's my pleasure to introduce Dr. Anita Manot, who's come from Montreal today to speak with us about perception. Anita is an OT and a associate professor at the School of Physical and Occupational Therapy at McGill University. And so we're really thrilled that she's able to share her knowledge and expertise with us today. And I'm sure she'll take a moment to introduce herself a little bit more. So welcome, Anita, and please go ahead.
Great. Thank you very much for the kind introduction, for the invitation, Sue. I really appreciate it. And I really look forward to meeting you all, obviously online, but meeting you and get to know you and just to interact with you and share knowledge and share from your experiences in regards to managing visual perception impairments post-stroke. So I look forward to a lot of exchange today and the next coming days that we're together. And so just for a quick introduction about myself. So as Sue mentioned, I'm an occupational therapist, graduated at McGill University, and pretty much primarily had my clinical practice and experience in stroke rehab. It's been a really area that I'm very passionate in. And so I also then went on to doing my master's at McGill in rehabilitation sciences, where I really had a keen and specific interest in regards to unilateral spatial neglect post-stroke, and so wanting to learn more about assessment and treatment in regards to this area. Then went on to do my PhD at the University of Toronto, where I wanted to really look at what are ways that frontline clinicians can really incorporate evidence-based practices in their daily practice. And so really looking at strategies and ways that we can learn and incorporate that new evidence in our clinical decision making. And so I did some training in knowledge translation with Dr. Sharon Strauss and pursued my my PhD as well. I've been also mentored along my way with Dr. Nicole Korner-Butensky, who is also known to be internationally known as a stroke rehab expertise. I also am now a associate professor at the School of Physical and Occupational Therapy. And so I teach a lot of the neuro courses, stroke rehab, and courses in knowledge translation, along with being chair of the KT committee, really looking at, sharing what's out there in terms of latest best practices for stroke rehab and just getting that implemented in daily practice. I'm also the associate member of the Institute of Health Sciences Education. So I have a special interest in pedagogical approaches, and also as well a mother and wife with 3 kids. So that's just a quick intro about myself. And so I'd like to hear a little bit more about you. So I think the most efficient way, since we're a larger group, would be through a Zoom poll, but I'd like to know a little bit more about your professional training, your clinical experience with stroke, just your area and just level of comfort or competence with visual perception and neglect. And so where do you specifically work along the continuum of stroke care? So perhaps, Sue, if you can kindly just launch that poll and we can hear more from you.
Hi, I'm Susan Black. I work at Geraldton District Hospital, and we're a small kind of rural hospital. I've had a long career. Stroke has always been an interest as well, and I've been a generalist therapist though. So my current role here, we certainly see stroke clients, not a large number. My challenge is there's no physio here at the moment. So trying to treat balance and lower extremity and upper extremity, and also address the perceptual deficits, you try to put it all together.
Yeah.
One of my challenges with a stroke client when they've had a more devastating stroke, and there's a lot of perceptual deficits, is really how to accurately sort of assess what's going on when there's aphasia and lots of different things. So
Thank you,
Absolutely.
Susan. Geraldton's
Yeah.
from up north.
yes,
Just
we're
so Anita's aware.
Yeah, oh, okay. Yes.
Yeah. And thank you, Susan. So if you want to mute, I'm going to just launch a poll and have you guys everybody present today, click on the poll and answer some questions so we could kind of quickly get to know people.
Yeah. But thanks for sharing, Susan. Just in reflection of that, like I agree, assessment is really critical in really figuring out, what would be key assessments to use, given that clients often have aphasia. And so how can we get around that? And so I'll definitely be addressing that in our day 2 of the workshop, where we're looking more specifically at assessment. So hopefully I'll be able to address your questions then as well. So I invite you all just to answer the questions on the poll, just so I can get a better sense of who we have in the audience, in terms of health professionals, your level of comfort with the topic area, and your experiences as well, and where you work along in the continuum of care. And we'll have plenty of opportunities to have an exchange as to what has been your experiences in dealing with visual perception in USN, and I'd love to hear more about that as we move along in the lecture slides.
Just so people know, just scroll down. There's 5 quick questions in that poll. And if there's more than one in the room, you can answer however you'd like, but you'll probably only be answering for one person.
Oh yeah, that's true. Yeah.
That's
Anyway. It's just to give us a flavor, so that's great.
Yeah. Give it one more second. Someone's requesting captions, so I'm going to see if I can do that. Okay, I'm going to end the poll.
Mm-hmm.
Share the results. Do I have to scroll or can you?
No, I'm good, so I can scroll and see.
Okay.
So perfect. I'm just taking a quick note of this, just so I have a sense.
Somebody's having trouble with their volume, which is at max, and they can hardly hear.
Oh, okay.
I can hear you well, so I'm not sure if you just need to be a little bit closer.
Myself, yeah, like to the mic.
Yeah, I think so, but typically it's a problem at the other end, right?
Mm-hmm. Okay, great. So I can, I'll stop sharing and I'll try to speak a little closer to the mic. But if it can, just let us know in the chat if it gets a bit better in terms of volume. Hopefully you'll be able to hear. Okay, so I'm sharing this result. So we'll move forward. So, I'd like to again, sorry, just close that. Again, I'd like to hear, so thank you very much for sharing. It gives me a sense of a bit of, how your experiences might fit with the learning objectives. But again, I'd like to hear more in terms of if there's any specific learning objectives that you have as you've registered for this course. Feel free at the end to send me an email, and I'll try to see if there's something I can adapt and make sure to address in the next coming days that we're together. So kindly, feel free to share an email and share your learning objectives. If you have specific ones that you feel may have not been touched upon when I present the learning objectives of the course and the content to be covered. And so hopefully, this meets your expectations in terms of what you were hoping to gain and learn from this workshop. I, again, would, love to hear more about your past experiences with managing visual perception and neglect. And so I'm really hoping that this workshop today and the next coming 2 days will be, something that's very interactive, where you'll have a chance to hopefully learn and apply this knowledge into your daily practices. But also, I would, really enjoy learning from you and hearing more about, what have been your clinical experiences in regards to dealing with these clients, and what have been the challenges and obstacles, and what have been strategies that you found worked to overcome them. So we'll be talking a little bit more about that. But maybe just to get started here, I'd like to hear just a bit of, we heard a bit from Susan, but just quickly about any of your current practices or experiences with visual perception and neglect. What have been assessment tools that you've frequently used, and what have been any practices that you've had just from your experiences? So if you would like to go ahead and unmute and just share, or you can indicate it on the chat as well.
Maybe the IRU can unmute, but I feel like maybe the BIT assessment isn't really used too much across HSN and Sudbury. You could speak to that.
Okay, so the BIT, you're saying the BIT has been somewhat...
The BIT, yeah. Sorry, I call it the BIT. That's wrong, isn't it?
Sorry, yeah. No, that's it, the BIT. And okay, I've also tried to increase my volume on my end. Hopefully that helps with others. So the sunny side, neglect, okay, great. Excellent. So we'll be looking at the line by section today, but those are great assessments to use. So we have got the sunny side, neglect, MVPT, stars cancellation, belt cancellation. Perfect. A lot of tools specifically looking at, and we're going to talk about the different hemispaces and what that looks like as well for assessment. Star cancellation, line by section, and the OZOT, yeah. Okay, great. Thank you for sharing. Great. So I'll keep going, and then we'll again have more opportunities to share a little bit more of what we've done in the past, or what are tools that you've frequently used in your practices of visual perception and unilateral spatial neglect. So here are just the learning objectives. And again, hopefully you have a copy of the handouts or slides, and you will receive another version of these handouts. So as you can see, my version that I'm using today will have responses to some questions that I'll be asking in between, in terms of little quiz questions of material that we've just covered, just making sure that everyone's on the same page and everything's well understood. So I will be sending the version that I have right now posted to you as well. So you have your handouts, but you'll also receive all the responses to the quiz questions as well. I'll be sending it to Sue later on. But these are quickly the learning objectives of our workshop today. And so what's really great is that it aligns really well with the Ontario Stroke Core Competency Framework, which I'll just show here as well in the next slide. So you can see that, what we'll be addressing today is a lot of, what we see in terms of common visual perceptual changes post-stroke and its impact, and what are kind of strategies that we could use in terms of assessment and treatment. So a lot of the learning objectives or learning outcomes that have been outlined in the Stroke Core Competency Framework will be covered today. So hopefully, that addresses your learning needs. So this is sort of the plan for our workshop. And so it's a 3-day workshop where day one, this is the material that I'd like to cover. And then I have, you can have a sneak peek at what's to come on day 2 and day 3. But today I'd really like to, start off with we've already done our quick introductions, but, understanding a bit more about visual perception. We'll just dive into it a little bit deeper, understanding the prevalence and impact that it has on function, as well as unilateral spatial neglect, or USN. really understanding the intricacies of this very complex impairment, and looking at prevalence and impact as well, and then really understanding the roles of different team members that we have and how this can really be an interdisciplinary team effort. And so just recognizing those roles of the other members of the team, and how, what roles they can play in managing these two impairments. We'll really dive into the best practice guidelines, really understanding what has been recommended across Canada in terms of best practice guidelines for stroke, and specifically related to visual perception and unilateral spatial neglect. And then what have been, from research that was done, and in fact, this was work that I did as part of my master's and some part of my PhD, really understanding what are the existing gaps in clinical practice regarding visual perception in USN. And what could be certain barriers and facilitators related to how we manage these two impairments. And then this is really where I would love to hear from you as to what have been certain barriers and facilitators that you've encountered in your practice. So that's what we're going to cover today. And then in a nutshell, for day 2 and day 3, day 2 is going to be primarily screening and assessment of these two impairments. And we'll really do more of a hands-on activity in terms of looking at the MVPT, the line bisection, and the bit as well. And then finally, day 3 would be covering we'll really touch quickly on neuroplasticity and looking at principles of neuroplasticity and how they specifically apply to treatment interventions related to visual perception in USN. What have been the best practice guidelines, and what have been evidence-based approaches specific to treating this impairment. So that's what we'll be covering. And then as well, again, I'd like to hear back from you in terms of feedback and in terms of strategies, or what have been, treatment interventions that you've tried out in your practice, and what has worked and what have been sort of stumbling blocks that you've encountered. So that's our plan. So now diving into visual perception. So when we look at visual perception in general, it's really, a very dynamic process where, again, we try to receive information through primary sensory inputs, and then try to process this information, into something that's more meaningful. And it's, again, based on what have been our past experiences or our past visual experiences that we've had of that environment. So really drawing upon what we've had, what we've learned in terms of our experiences, and really converting those primary sensory impulses into meaningful information. So it's that raw data that comes into, into our visual cortex, into our, into the visual systems, and then gets processed into information that can be then manipulated and perceived and then used for decision making. So again, if we look at the very bottom levels, and we, in terms of the hierarchy, visual perception and its processing really happens in that hierarchical fashion, where all these different levels and systems really depend on each other. So that very basic raw data that we receive from the visual input, in terms of it gets processed, and it's known to be more visual acuity and visual field. And then as the information gets sort of dispatched to different areas of the brain, it then starts to sort of really convert that information into more meaningful information, and it really incorporates other parts of the brain to really process that information. And again, all these systems are really dependent on each other. So again, just to review very quickly, we've got the sensory visual impairments that happen post-stroke, and then visual perceptual impairments that as well happen, where the sensory visual impairments, where we see, symptoms like hemianopsia, diplopia, nystagmus, blurred vision. This is really where there's damage to more the visual or the primary visual cortex. And so it's very specifically the posterior pole of that occipital lobe that's affected, and it's really impairing or infecting functions related to eye movement, and really being able to see clearly, and our visual field, really be able to see both parts of the right and left visual field. So that's really like the function of the primary visual cortex. And then finally, like if you look at more higher level processing and looking at visual perceptual impairments, this is really tapping into the other lobes of the brain, or looking at more the occipital lobe, the parietal lobe, and the temporal lobe. And so you're looking at more higher level processing of visual attention, visual memory, visual spatial impairments, more like neglect, and visual agnosia as examples of impairments that we can see post-stroke. So really looking at, dependent on where the brain's been affected, it'll present itself as different impairments that you will be able to screen and assess for. And again, during the presentation, please feel free at any moment to just unmute, ask a question, interrupt. I really welcome all your questions. You could also use the chat as well, but feel free to just unmute and ask me any questions that come up during the slide. So in terms of, so that's quickly, in terms of pathophysiology, but if we look at prevalence, it's quite a prevalent impairment, so visual perception specifically. So very recently, there was a large prospective trial that was done with 1,033 patients post-stroke by Rowe and colleagues. And so they found that roughly 50 to 70% of stroke clients do have that very primary sensory visual impairment, but that 76% of stroke clients could present with visual perceptual impairments in general. And there's a much higher prevalence of perceptual problems in those that are patients who have dysphagia or who are dysphasic, rather, like with language impairments, compared to non-dysphasic clients. And even though that there's no subtests, even these subtests that are used to really detect the presence of perceptual problems, even though they don't actually require any kind of expressive language. So we did find a high prevalence of clients who have perceptual problems and those that have aphasia as well. A lot of the impairments that we find are also on inattention tests or tests of neglect. And we definitely see a significant number that have a combination of different visual deficits. So they have a combination of either sensory or perceptual deficits. And so, when we look at more sensory deficits, it's really hard to tease out, whether these impairments were really existing prior to the stroke or not in these studies. So that's kind of something that may cloud some of the findings, but that we definitely see, though, in clients with a stroke, that there's definitely a huge sensory, visual, and perceptual component that we need to consider. In terms of impact, this is something that we see very clinically, very prevalent, is that, it has a very significant impact, of course, in many areas of function, but also specifically in terms of mental well-being. So we've seen a link or association between those with visual perceptual impairments and their mental status in terms of their mental well-being, in terms of their increased risk of falls, quality of life, and then their recovery post-stroke. Also, we do see that when we actually do provide very effective management strategies, so when we assess and when we treat clients with visual perceptual impairment, we could see significant improvements in their patient outcomes. So really, very important to detect the presence of visual perception and USN deficits, and really provide clients with appropriate remedial treatments to improve function. So this is just a quick review slide, just to run through various categories of visual perception, specifically also for those who aren't, working with this clientele or working with this impairment on a day-to-day basis. So I just wanted to run through and just review, the categories of visual perception and the different characteristics. And it's a nice review as well when we dive into the MVPT, or the motor free visual perceptual test. It really provides us with a nice overview of, what are the different domains that are assessed by this tool. So when we look at visual acuity, it's really being able to clearly or sharply see an object within a given distance. And so when we look at visual acuity, we also test for color vision, and really looking as well at the visual fields, which is where we see clients who have the presence of hemianopsia. So this is being able to, really scan the visual field and see objects in our environment clearly, such as be able to read road signs or traffic lights. Visual discrimination is really being able to see very very tiny differences or similarities between certain objects. So when we want to look at foreign currencies and really looking at the differences and discriminating between an American coin and a Canadian coin would be visual discrimination. Visual figure ground is really where you're trying to identify an object within a very busy background. So being able to really perceive or see objects that are in a busy cupboard or in a fridge would be important for visual figure ground. Again, a lot of these skills are very important for driving, and you could just imagine a combination of these skills would be definitely required. Visual closure, again, looking at the ability to perceive an object even when it's partially hidden. So you don't, you get a tiny piece of it. So for instance, a stop sign that's covered with snow, but you're still able to perceive that it's a stop sign, even though you don't see the complete object. Visual memory or pattern recognition is really being able to recognize certain letters or numbers. And again, very important to be able to recognize those letters and numbers for reading, and it's an important component. If we move forward, it'd be visual sequential memory. Again, being able to, remember the sequence of words. So again, very important to have visual sequential memory for being able to read and write. So really remembering the visual details of a sequence. Looking at visual form constancy. So this is where, you're able to see an object in different environments or from different angles, but you're still recognizing that it's the exact same object. So recognizing a dog in a photo versus being a dog running outside in a park versus sitting, and not moving in the same manner, but that you recognize that it's still a dog. So that's visual form constancy. Then there's visual perceptual or spatial relations. And so that's more looking at visual spatial neglect or visual neglect. And so there's different words to use, or visual inattention that's used to sort of describe the same thing, but it's really tapping into visual spatial neglect, and which is again considered as a very high level in terms of visual processing in that visual perception hierarchy. And so what's really important to keep in mind is that an individual could have issues with visual spatial relations, but still have normal visual acuity. So they could have very normal function in that sort of hierarchy below, in terms of having normal vision acuity, visual acuity, normal visual field processing, but that yet still in that higher level, they can have issues with spatial relations. So this is where they have difficulty with reading a map or bumping into obstacles in their environment. And we're going to talk a little bit more in detail about how do we recognize the difference between hemianopsia and USN, which is often sometimes tricky, but there's ways that we can look at really screening between the two impairments, because sometimes they could present very similarly, where individuals tend to bump into obstacles, but it could be either neglect, it could be hemianopsia, or it could even be both. So really teasing that out would be important. Visual motor integration, so being able to really visually process information, but react as well using a motor action, so catching a ball. Visual agnosia is really looking at being able to recognize certain objects, being able to recognize certain objects through touch and sound, but unfortunately unable to recognize those objects using visual input. So you could basically describe certain familiar visual objects. You can touch and hear the object, and you're able to describe what that object is, unfortunately, but when you see the object, you're unable to actually recognize it. So it's that visual agnosia that gets affected. And this happens even though the individual has normal visual function, but they're unable to recognize visual objects when they see them. So as you can imagine, individuals have a combination or very specific categories of visual perceptual impairments, and this can have significant impact in terms of occupational performances for our clients. And so, we can see that in all areas of function. So I'm going to take a moment, and again, it may be a quick review, but this is just a refresher, just to make sure that we're all on the same page when it comes to visual perception. And so just a quick, a quiz to just keep things interactive and fun. So I'm going to ask you a few questions. I'm going to show you a few images, And basically, what you're going to be doing is you're going to be identifying the category of visual perception. And I see here Susan has a question. If you can read, does it mean that you have all the basic skills, visual closure and discrimination? Yes. So Susan, great question. So if you're able to read, yes, I agree that you're able to have those aspects because again, visual closure, discrimination, they're very much important. You may still have issues with visual discrimination and just, because it does require a different level of visual processing where you're really trying to find very subtle differences in detail. So sometimes reading could be fine, but you could still have issues with visual discrimination. So again, it also depends on where the information is being presented, right? So if you look at, if information is really presented on the right side, if you have a right hemisphere stroke and you're neglecting the left side, if information is presented towards your right side, you should be able to read and process things as well. So yes, you can, you're definitely able to read when you have those basic skills. But once you get to those higher level skills like visual spatial relations, it becomes a bit more challenging. So any other questions about what I just quickly covered in terms of visual perception? I went through it fairly quickly, but I just wanted to make sure that hopefully sounds good. Any other questions? I don't see anything else. Okay, so we'll go with the quiz. So I would encourage you can also go ahead and answer. So yeah, let me just see how. So Sue, are you able to post the Zoom poll?
I am. It's all 6 questions in the same poll. So do you want to go through the 6 pictures first?
Well, unfortunately, I won't be able to go through all because it'll be I'll display the responses. But if you don't mind for the participants, if they can just go through the handout to view each of the images.
Pictures?
Yeah, the pictures. Yeah. So you'll basically look at slide 15 right through slide 20, and you'll be able to see the images on your end and just answer the questions as to what are the categories of visual perception.
So I did label them. Number 1 is the stop sign picture, which is shown on the screen here. Number 2, the matching socks. So they are labeled. Just as a little aside, Anita, do you have a closed captioning button on the bottom of your screen that you could click? Because I don't have it. I've been looking for it. I just noticed it on your slide there. See it on the left of your slide, the CC button?
No, I don't seem to see. I see annotate, remote control, and then I see more. And I don't see an option for closed captioning.
Okay, I'm going to sort that out for our next time. I apologize to the person that requested it.
Okay.
Don't be shy, people. Throw in your answer and we'll be talking about them.
We're just waiting for the next slide, right?
Oh. Second here. Oh, no, so are you able to go through on your end on the handouts?
No, there's like a poll quiz here and that I'm just answering.
Okay, okay, so because you need me to go through, it's just that unfortunately the responses will end up showing, but,
Well, I sent you the handouts, so if you had the handouts that I sent you, and I might have attached them in the meeting request, you can open your handout on this on your own computer and look at the 6 slides. Are you able to do that? I'm not sure who that was.
Oh, that's me, Joby. I'm just gonna look at it. Okay.
thank you.
Yeah. Thank you. So this.
Oh, yeah. Wait, Sue, I think we have more than half about that have completed so far, so maybe we can just end the poll if that's okay. Yeah, if that's okay, I want to move forward,
Yeah.
yeah, we've got quite a 60%, so we're good. I think we can.
Do you want the results shared or no?
Yeah,
Yes.
sure, thank you.
Okay.
And then we'll just go through, and then you can, feel free to unmute and we can discuss the responses. So,
Just let me know when you want me to stop sharing the results.
yeah, okay. So, well, I'll keep the results here just so that I can go through the question. So it's all good. Okay, so for the first question, it's really looking at visual closure. So I think that's what the majority had responded. So it really fits with, where you don't really have all the information, but you're able to complete the image and really decipher what it looks like. So that's the stop sign. Matching socks, again, so that's the second one. And it's really looking at visual discrimination. Again, really trying to, pay attention to the little details. And so that's the response for number 2. That's visual discrimination. And so that's what the majority had mentioned as well. And the third one being trying to find sunglasses in the drawer. So again, the majority mentioned that it's figure ground, and that's correct. So it's visual figure ground, where you're really trying to find your item in that messy drawer. And so that's the skill that's required there. And then we've got Baby Yoda in a movie clip. So it's really looking at, so a part of form constancy, exactly. So, where you've seen that image somewhere, but it's again presented in different environments and different perspectives. And so you could still recognize it as being that same object. So that's number 4. Number 5, you've got, French currency. And so really trying to identify which one of these coins is really the French currency to use. And so really looking at very fine detail, again, visual discrimination, really looking at that fine detail to be able to identify which coin you need to use to pay. So that's question number 5, looking at the currency, French currency. And then finally, number 6, so we looked at Google Maps and being able to really read the Google Maps on an iPhone. So looking at something on an iPhone and really looking at it, in another dimension and being able to really figure yourself out in space. So that really taps into spatial relations, which you had, most of you had indicated as well. So really tapping into being able to really understand your position in space and be able to navigate that. So I'll stop sharing that. Perfect. And then we'll move forward. So I don't know if you've had any questions based on that. And just to go back to Susan Black's question about earlier, I'm just going to go back my slides again. I just wanted to go back to one. She had a question about reading. And so, and whether it taps into the more basic levels of visual perception. And yes, so you can, it could be looking at very sort of basic lower levels, but as you go higher into pattern recognition, which is again important for reading, a bit of visual memory, but really pattern recognition. But as you go higher up, that's when you start to get to higher levels of visual processing. That's where you start to, you're looking at also the spatial relations, and that's where things become a bit more difficult. And so that's, really tapping into higher level skills of visual processing. So let me just get back to where I was. Oh yeah, okay. So that's just a quick snapshot on visual perception. Now we're going to dive into looking a little bit more at unilateral spatial neglect. So neglect is really well, it's known to be a disabling feature post-stroke. It's quite common, but it's really that inability to attend to the side that's opposite to the brain lesion, right? So, of course, if you've got a right CVA, that you would have the left side that isn't attended to. And so this is a very basic definition of USN, but I feel, and this is where we often find, challenging, is that it's not even sufficient enough for, as clinicians who have experience in this area, it's not really sufficient enough to really adequately or successfully assess and treat this population. That's why we need to really understand a little bit more about the intricacies of neglect, which is what I'd like to go through in the next coming slides. So, like I said, neglect is quite complex, and there's different types of neglect. We've got the more visual or sensory neglect, which is what we're going to focus on today. It's really where there's issues in terms of input. So, where we have the inability to perceive objects, and so we don't tend to attend or basically pay attention to either visual, auditory, or even sensory stimuli that happens, anything that just seems to be happening on the neglected side or the affected side, right? So that's what ends up happening. So it could be either visual input, it could be auditory input, sensory input, or even a combination of those inputs. But basically, the individual doesn't attend to that other side, that affected side. Motor neglect is really interesting, where it's a bit different, where you have issues with in terms of output. So you're basically unable to initiate motor movements on that affected side, even even though there's stimuli, but this cannot be explained by any kind of weakness that the individual has. So they may have normal motor function in their arm, but unfortunately, they're unable to produce that motor output, or if you ask them to raise their arm, they're unable to do that, to produce that movement in response to stimuli, or you asking them to on that affected side. So that's labeled as a motor neglect. And then finally, we've got representational neglect, and this is really interesting. This is where an individual tends to, when you ask them to describe their bedroom at home. So if you think, in your mind, what does my bedroom look like? What's on the right side? What's on the left side? Where's the window? They're not able to basically describe the space that's on their affected side. So they're not able, if there's a window that's position or that's there on their left side of their bedroom, they're not able to describe that there's a window on that left side. Yeah, even though, and this is not explained by any memory loss. So they have intact memory, but they're just unable to describe that familiar environment. And so that's representational neglect. And then on the top of that, we have azoagnosia. So this is where azoagnosia is really where an individual is really having that lack of insight as to their failure to attend to that other side, that neglected side. So they really are not aware of their USN symptoms. Now, generally, you'll see with clients who present with neglect initially, even clients sometimes with hemianopsia, which is different. They often are maybe, of course, hemianopsia, they're more aware of their symptoms, so they're more aware that they're part of their environment is, they can't see part of their environment. With neglect, they're often maybe not aware of it, but that with azoagnosia, even if you bring it to their awareness that they're neglecting a complete side, or you cue them repetitively, they still, lack that insight, and they're still unable to correct. And so this becomes very challenging in terms of treatment. So this is really another very severe form of neglect, where even with cueing, with auditory feedback, with sensory stimuli, you try what you can, but it's very difficult to get that individual to attend to their neglected side. So that's azoagnosia. But not all clients have azoagnosia. There are clients who have neglect, with the lack of azoagnosia. And then, so that's one part of neglect. So something that we need to consider, different types of neglect. But when we simply talk about unilateral spatial neglect, or that spatial impairment, this can happen to different hemispaces. So if you look at the person's environment, neglect can occur either to their personal space, which is neglect of their body, right? So that's directly their body space. It can happen to their peripersonal or their near extrapersonal space. This is where they're neglecting the space within their reaching distance. So everywhere within their reaching distance is on their left side. If they have a right CVA, is spaces that they're neglecting. And then finally, far extrapersonal spaces really neglect of the space beyond their reaching distance. So this is where they tend to, to ignore obstacles that are really in their far environment. And so as you can imagine, a person with personal neglect or personal space neglect will have issues with, self-care, being able to shave, for instance, brush their hair, just, any kind of types of grooming will be difficult. Persons, or even with dressing, individuals with near extrapersonal neglect will have difficulty, may, eat food only on half of their plate, may knock things on their tray table. And then individuals with far extrapersonal space neglect really have and these are actually the individuals that are often quickly discharged home, but that have very serious sequelae or consequences once they get back into the community, in terms of being able to reintegrate, being able to cross the street, drive a car. These are the cases of mild USN that often aren't detected early on. These are individuals that seem to bump into obstacles, and they may be very functional in terms of ambulating, but they may be actually neglecting and can explain why they tend to bump into obstacles in their environment. So again, very important implications in terms of assessment and treatment, where we need to really discriminate, with our individuals who have a stroke, who possibly have the presence of neglect, really screening and identifying, what type of neglect do they have and what spaces are being affected. Because what we see in the literature is that that an individual with neglect can have neglect in one or a combination of any of these three hemispaces. Okay, so yeah, Sue, you have a hand
Yeah, I
up?
just wondered about when you talk about each of these areas later, will you be talking about the assessment tools that are best to detect these three areas? Because I'm thinking about the beyond reaching distance, the extrapersonal, and they get discharged early from inpatient, and maybe our outpatient programs would be really quite interested in the type of assessment you might do for that.
Yeah, so so of course, absolutely. Thank you, Sue. And, like this is where like some of the tools that have been recommended, although they are considered and recommended by the Canadian best practice guidelines, some tools, like there's been some tools that have been developed to assess the far extrapersonal space. But there are some tools that don't, that are really great, but haven't been tested psychometrically as much. And so, but fortunately, we do have tools out there. And so I will be covering, which tools are best for which spaces and which tools cover which spaces as well. So thanks, Sue. Yeah. So now, just to add on a final layer to the complexity of neglect. And so, we see that neglect, there's spatial neglect. Of course, there's different types of other types of neglect. There's neglect that can happen in different types of hemispaces in our environment that we need to assess for, but that we also need to think about sort of the frame of reference. And this is where, we say that USN can occur, in two types of frames of reference. So it could be considered as more self-centered, a self-centered frame of reference, or an object-centered frame of reference. And what that means is that when USN happens within a self-centered frame of reference, is that the individual, this is our typical neglect. This is what we see usually. This is where they fail to notice objects that are on their neglected side. So this is where they, when they reproduce a drawing, or when they try, when they reproduce a drawing, they actually, are able to draw parts of the diagram, but whatever is presented on their left side, they pretty much ignore, right? So that's what we typically see, clients who ignore really everything that's happening on their left side, right? For those who have a right CVA. However, there's this other special type of neglect that could happen, which is called allocentric or object-centered neglect, which uses a different frame of reference or reference frame. This is where what happens is that the individual can actually attend to their left hemispace, okay? But what actually happens in these clients is that they basically see they basically ignore the left half of objects. Okay, and it doesn't really matter where those objects are presented in space. So it could be if the object is presented in the right space, they still ignore the left half of it. And if the object is presented in the left hemispace, they still ignore the left half. Okay, so no matter where the object is, the left half is always ignored. And that's really allocentric USN. And we have an assessment tool that actually assesses for that. And so that I'll introduce. Hopefully I have time. I've tried to pack in as much as I can in the presentation, and I feel like, you know, the 2 hours is very short, but you know, for the assessment, but I will do my best to cover. You know, I don't want to speed through either, but I will do my best to cover. And what I've done is I've added all this information in my slides. So if we don't get to cover it, all the information is there on the slides. You have it as a resource and you can go back and read it. So, but in fact, there is a tool that assesses for allocentric neglect. And what we found was that, interestingly, patients with allocentric neglect, they actually scored lower on the Barthel index as opposed to those with egocentric neglect. And so basically they did worse in terms of functional performance compared to those with the typical neglect that we see, which is known as the egocentric neglect. So that was really interesting. So unfortunately, these individuals have, poor outcomes, and probably could be picked up much easy with that assessment tool. So we'll look at that later. And just to take out the suspense, the Apples test. If any of you have heard of the Apples test, that's the test that really discriminates between egocentric and allocentric neglect. So in terms of prevalence, what we see in terms of prevalence of USN, so roughly 30% to 40% of those with right hemisphere stroke, they experience neglect. So it's pretty high. And roughly 20% to 45% of these individuals, the neglect actually sort of spontaneously recovers. And then what we see is that those with a left CVA, 20% experience neglect, and again are most likely to resolve by that 3-month period. But we actually feel, or what's been documented in the literature, is that the percentage must be much higher, because in fact what we do find is that it's very difficult to assess clients with aphasia, and so that's a bit of the challenge. But I want to sort of explain more anatomically, like when we look at the brain, what really explains this discrepancy? Like, why do we see that we have more individuals with USN who have a right CVA as opposed to left CVA? It's not always explained by the fact that those with the left CVA have the aphasia that kind of impedes their assessment process. Anatomically, actually, we see reasons why, or that explain why this prevalence is higher in those with right CVAs. And so I want to quickly explain that here in this next slide. So what we see is that, in fact, the brain, the way things are organized, that there's attentional differences in between the two hemispheres of the brain, and the way the brain organizes or processes information, visual inputs that they receive. Okay, so when we look at the first image here, this is really the healthy brain, okay? And so in a healthy brain, what happens in the right hemisphere of the brain is that it can attend to the right side, and it could attend to a visual input that's processed, and it can process that information, whatever's seen on the right side, and as well as the left side. So the right hemisphere is able to do that. And then the left hemisphere, unfortunately, is only able to process or attend to the visual information that's presented on the right side of their environment, right? So that's what we see in the healthy brain. So when you have a right CVA, what ends up happening is that the left hemisphere, the left hemisphere of the brain can only really attend to the right side. And that's why we see a huge prevalence of those with left neglect, is that it's only really able to attend to the left side, and it's very hard for it to compensate. Whereas when we have a left CVA, or the left side of the brain that's affected, the right side of the brain can see, objects that are on the right side, but it can also attend to the left side as well. The right hemisphere is able to compensate quite well, whereas the left hemisphere is not able to do so. And so that's why we see a greater prevalence of neglect in those with right CVA versus a left CVA. So really that anatomical difference, okay? But regardless to say that, doesn't mean that we don't assess those regardless of the side of the stroke. What's been, and you will see later on, what's been recommended by the best practice guidelines is that really we assess all clients for visual, perceptual, and neglect symptoms, regardless of the side of lesion, right? And that's what's been recommended in the guidelines. But this is just a little tidbit just to explain as to why we see more USN with bright CVAs. So when we want to distinguish clinically in terms of, how can we really discriminate between what a client has hemianopsia versus USN? There's different ways that we can do this. And this kind of taps in a bit of about assessment, but for instance, so this is the looks more the star cancellation test. And so what happens is that, regardless of the type of test, you've got a client who needs to really scan the page to identify a certain object. So it could be a star, it could be a bell. But as you can see on that page, there's plenty of distractors, right? And so what happens with someone, whenever we're testing individuals with hemianopsia versus USN, we see really distinct differences in the way they approach a task. Okay, so when we see a client with hemianopsia with a primary sensory loss or a visual field cut, what we see here is that they have a very sort of abbreviated search pattern, but they have a very a very organized strategy where they really scan from left to right and from top to bottom of the page, right? So they really follow that typical pattern and they scan the page, but they, of course, they have an abbreviated search pattern where they're really scanning the right side of the page. So let's just imagine if the client has a right CVA, they really are scanning the right side of the page and they're ignoring the left side. And so, but they have still a very organized pattern of searching for information. However, when we look at USN, it's very much disorganized. So they sort of have a very scattered way of searching for the object, whether it be a star or a bell. So it's they sort of look all over the place. It's sort of, they don't start from top to bottom and they don't do from right to left. So it's quite disorganized. And so I've added some YouTube videos if you want to take a look at, on your own time, very interesting videos about really, discriminating between the hemianopsia and USN and how we can go about doing that. The other thing that we see in terms of distinguishing between the two impairments is really looking at that vertical line. So when we look at that vertical line, that midpoint, right, of an assessment tool, or even just in general, when we're getting clients to scan their environment, what we see with hemianopsia is that the sort of midpoint is it's a very sharp line, right? They really see one half of their environment, and that line is quite sharp and absolute. Whereas those with neglect, there's bits and pieces that they're able to see across the midline. Okay, so that's what's different with neglect. The other thing with neglect is that when you present to them a test that has a lot of clutter or a lot of distractors, they tend to perform more poorly as opposed to presenting them with an assessment that has less distractors. And so that you'll see, that's sort of the reason why for USN, the assessment tool of choice is the line bisection test. It really has just those lines, right, that are presented to the client, very basic information, less clutter, less distractors, but really then hones into, really their presence of USN, yes or no, and it helps you really discriminate that. Whereas the more clutter you have, the chances are they're going to actually neglect more information on their contralateral side or their affected side. So that's something with USN that's specific. Oops, sorry. And then finally, of course, patients with USN tend to complete their test very quickly. So they have less sustained attention. And so that could explain why they kind of quickly, complete the test because they really ignore that left half of their space. And of course, what we could see with hemianopsia is we see a nice improvement over time. So even functionally, we could see that, right? Like the minute that the client is aware of their hemianopsia, they can quickly compensate for it by scanning their affected side. They could also compensate for it with cueing and practice in any test that they perform as well. So they're quick to adapt. Now, Of course, what we see in the literature is that, USN can really severely impact clients, in terms of their function. So we could see clients, of course, in hospital, in rehab, having, we could see the presence of neglect can actually lead to increased risk for falls and, affect functional outcomes as well. But it could also really impair these clients very, significantly once they try to reintegrate into the community. And so this is where we start to see very important deficits that are often hard to identify, right? Like it seems that the person's either confused, it's not often labeled as a neglect, and it's often sort of sometimes difficult to pick up. So we'll stop here and we'll go back to another little quiz from what I've just covered right now, in terms of, understanding like the complexity of neglect, and understanding the intricacies of neglect and really discriminating between USN and hemianopsia. So here, again, I encourage you to take a look at your slides. Or actually, I don't know, Sue, did we have them? How are they been combined again? I'm not sure.
Just like this.
Okay, perfect.
So
Okay.
I took the question from your slides and put each question in the poll so people can answer, see what the case is, and then personal space, near extra personal space, or far extra personal space, and then they can just scroll down.
Great. So you actually have exactly. So you have all 6 questions. You have all the information that you need to answer the 6 questions, and then we'll review the responses after.
Mm-hmm. I'll give you a time check. It's noon.
Okay, perfect. Oh.
We have about half the people have answered, so we'll give another minute maybe.
Sounds good.
We have 75% of the people done. Let me know when you'd like to end it, Anita. Do you want a few
Oh, yeah,
more?
I think that's good. No, it's fine. Thank you.
Okay, I'll end it. Do you want me to share the answers?
Yeah, I could see them.
There
So
you go.
yeah. Perfect. So, so in terms of responses, so I've already clicked a few times the response to the first question, so apologies for that. But so whoops, let me just try to get these responses in. So yeah, for question number 1, the client's hand is bruised as it's dangling near the wheelchair spokes and poorly positioned, and so that we see as a neglect of the personal space. Because it's really neglect of the space on their body. So that's where they're not paying attention to their body. And so often we'll see clients with their hands either poorly positioned or the body poorly positioned on their neglected side or their left side. And often, you know, especially when they're in a wheelchair, that could be pretty dangerous. And then their fingers are, you know, in between the spokes. And for the question number 2, we have the client is confused because he hears his daughter talking, but doesn't see her standing on the left side of the room. And so, and this is more considered as far extrapersonal neglect. Again, we don't really know how far this daughter is standing, but we could assume here that, you know, the daughter's a bit further from the client. Of course, if the daughter was standing on the left side of the room, but within the client's personal space or reaching distance rather, that would be neglect of the near extrapersonal space. So if the daughter was right at the bedside, you know, chances are they're within the client's near extrapersonal space, so it would be near extrapersonal space. But in this case, you know, where the daughter is actually standing on the left side of the room, and so it, you know, could be possibly even further, and so that's why it's neglect of the far extrapersonal space. But it's really just explained that this is really, it's not a personal neglect, but it's really a neglect in their environment. So now the third question is that this is really representational neglect, where oops, sorry, just move forward here. This is where the client describes his bedroom at home, but cannot recall the window on the left side of his room. So really being able to not remember the left environment from memory, or not able to recall the left environment from memory of a space that's actually quite familiar to the client. So, you know, this is where that client has representational neglect. And now the next question here. For the client knocking down his drink that was placed on the left side during a meal. So this is like any, you know, objects that are on their meal tray. So that's again, rightfully near extrapersonal neglect. So this is where the individual is neglecting the space within their reaching distance, and then essentially the space that's on their left side. Number 5, which is tendency
Anita,
to
can
drag.
I ask a question? Sorry.
Yeah, not a problem.
Number 4, why would it not be motor neglect?
Okay, so here, well, it's because what happens with motor neglect, it's really when you're asking the client to initiate a movement that they're not able to, like, they're not able to reproduce a movement on command. That would be more motor neglect. Yeah.
Okay, thank you.
Yeah. And so that's why it's not motor neglect, but it's more near, it's neglect of the near extrapersonal space where they're not able to see that object that's in their left space. Yeah, within reaching distance. So yeah, so then 5 is really the tendency of a client to drag their foot on the floor during ambulation and tripping on the door sill or bumping into obstacles on their left. And again, it's sort of a combination of neglect of their far extrapersonal space and personal space. So personal meaning that, you know, they're not aware of, you know, it could be that they're not aware of their body, and so or their body itself, you know, so that's personal neglect. But then it could also be that you know, they don't, as they're ambulating, they're not able to see that there's a door sill you know, in front of them, or that they're approaching a door sill, or they're not able to see obstacles that they're approaching on their left side. And so that's where they tend to have a neglect of the far extrapersonal space, because they don't seem to see objects that are beyond their reaching distance. So that's what we see. So again, the correct responses here are more personal space or or far extrapersonal space as well. Those could be the correct responses of really then being able to not perceive things in their environment. And then again, if clinically what you can do is to really discriminate between the two, you can definitely do that when you engage the client in more ADL. So if you get the client to either dress themselves or participate in bathing, you could definitely observe or see whether they actually neglect their left side in these tasks. So that could be one way to discriminate between personal space neglect and far extrapersonal space neglect, really in a task that involves their body.
Can you describe what a motor neglect would be in that sort of situation? Because many people chose motor for this one, so.
Yeah. So motor neglect, it's really where what it is that it's more when you're asking them to perform a motor movement. So like if you go back to 1 second here, I'll just walk us back. Sorry. Oh, didn't we just get back to that slide where we talk about motor neglect? But it's really where you're trying to get them to you're giving you're sort of presenting a stimuli and you're asking them to perform a motor movement. So I'm just going to get back here. So it's really that output issue is where they have they're not able to initiate that movement, even though there's that stimuli that's so meaning like if you're asking them to to lift their arm up, or you're tapping their arm and you're asking them to lift it up, they're not able to produce that motor response on the affected side, even though they have complete motor function of their arm, and even though they don't have any issues in terms of sensation.
So if you ask them to step over the door sill and they weren't able to do that, that would be motor neglect?
Exactly. So you're asking them to
Okay.
but sometimes what would happen is reflexively they're able to actually do things. But then when you actually ask them to do things on command, they're not able to do it. So you see this discrepancy between their motor output, and so you're sort of wondering, because they do present with full strength in their arm. They are able to feel their arm. They have sensation. They have full motor function, but they're just not able to reproduce those movements when you're asking them to.
Right.
Yeah.
There's a question in the chat, but we can wait till the end of the quiz if you'd like.
Okay. 1 second. Let me just get back to where we are. Okay, so well, yeah, I'll just do that last question. So yeah, so this is where the client naturally swings their right arm during ambulation, but does not do that the same with their left arm. So even though it has full range of motion, so they're being asked to walk, and they're able to move their right arm, but they're not able to do the same with their left arm, even though it has full range of motion, even though there should be no motor problem. And so that's more of a motor neglect. That's how we see motor neglect presenting itself. So hopefully that helps clarify. And maybe we can go to the question now. Oh, okay. So so you were asking Nadina, like, how do you differentiate between motor neglect and proprioception? Yeah, that's a really great question. Again, it's more like it's very similar to motor apraxia, I think, is what we can look at it as. Like proprioception is really understanding the joints position in space, right? That they are not able to really understand where their joints position is in space. And so, proprioception is really where, you're getting a client to close their eyes, and then you lift their arm and they're not aware of their arm in space, but when they're able to use their vision, that's really where then they're able to say, okay, yes, my arm is lifted right, to 180 degrees or 90 degrees. It's able to really identify where they're able to use their visual input, in fact, to perceive where their arm is in space. So that's proprioception. Because often when we test for proprioception, we're trying to get the client not to look, right? And so that kind of differentiates between motor and neglect. Hope that helps, Nadina. I don't know. Feel free to answer either on the chat or unmute And I'm happy to answer if you have any other questions. No, so far so good. Okay, so we can continue. Let me share the results. And okay, great, thank you. So now the next question, or so the next series of questions is here. So Sue, I don't know if you can kindly just share the next set of questions. Oh, this is the neglect poll.
I don't have it. I don't have it, sorry.
Oh, no, that's okay. If not, no worries. I can just people can shout out the answer and we can do it that way too.
I think we might have said we would do it that way.
Okay, perfect. So, so now for the next series of questions, what I'd like you to do is if you can kindly take a look at the slide. And so if you see here on the top, here's a diagram, you know, of a house with a tree, flowers, and a vase with 2 flowers here. So this is what the client needs to reproduce, right? And so it's the stimuli. And then here below, we've got 3 pictures, right, of a reproduction of a client who's reproduced it. And what I'd like you to identify is whether this row of images or drawings that the client has done, if it represents egocentric or allocentric neglect. So this row here, what would your thoughts be based on like what we've talked about in terms of ego or allocentric neglect? So here I welcome you to unmute, or you can just write in the chat. What are your thoughts about this one?
Egocentric.
Yeah, egocentric. I don't know if any of you guys agree, right? So it's really where the individual is like able to reproduce items that they see on the right hemispace, but stuff that they see on the left hemispace is completely ignored, right? And so that's what we see represented by the images D, E, and F. And then the next one, maybe it might be fairly obvious, but anyone want to take a guess? Yeah, I see here Susan said allo. Exactly. So it's allocentric. So exactly. So this is where we see that some, you know, some aspects of the drawing, the left half rather, has been ignored, right? So if you look at, and again, not all objects, but like some of the objects you see here, right? Like you've got objects that are on the right and on the left, and the objects, you know, have really the left part of the object that's been ignored. Same thing here, like you don't have a complete drawing where it's very different. Someone with egocentric neglect, they will really complete that drawing on that right half, right? The right hemispace. You'll see a complete drawing on the right hemispace and a complete blank on the left. And what we see with allocentric is not that case at all. Like they actually have a drawing on both the right and the left page, right? The right side of the page. But that the left half of each drawing or each object is missing, right? So that's what we see. It's very, very unique. So egocentric and allocentric. And then in terms of hemianopsia, so this, oh, sorry. We'll go back up here. Anyway, I went through it quickly, sorry about that. But if you look at this image, again, we see an image and the client has highlighted the stars or asked to highlight the stars that they see on the page. And this is where we see would be more identified as hemianopsia because it really is, you know, they've really identified objects that, you know, on one side of the midline, and it's really like a clear-cut, very distinct image. Again, it could be USN as well. So this answer could be debatable. It could be USN, and in fact that they really are neglecting all the space from the midline and the left. And it could possibly be that someone with USN could, you know, present with these responses, but when we, you know, once we do further testing, we can then easily more discriminate whether it's hemianopsia or neglect. But in this case, you know, given that it's really a straight line across the midline, and that, you know, only items that are identified are really on that right side of the hemispace, it is really more hemianopsia than USN. So let's look at the next one here. So what would this be? Would this be more hemianopsia or USN? What are your thoughts? You can add it in the chat or unmute, whatever you feel comfortable with. What are your thoughts?
Make a guess.
Got 50% chance. Yeah, so Susan has said USN. Yeah. And that's a great guess, exactly. So really it's USN. Why? Because again, we're seeing that it's not a strict, clear midline that we see the impairment in, and that they're neglecting, or they're able to still perceive bits and pockets of their left hemispace, but that the rest of the parts are really ignored. So it's not that clear-cut line that we see in hemianopsia. So what about here? So which would be more USN and hemianopsia in these two drawings? The more organized search patterns versus the more just sort of messy or disorganized search pattern. So maybe somebody can unmute and say which one. Yeah.
The one with the more organized pattern is hemianopsia.
That's right, exactly. And then the one with the more disorganized is more USN. Really sort of, that's sort of the way they are searching and organizing the information that they visually perceive, right? So and it really speaks to the fact that it's a higher level perceptual disorder, as opposed to hemianopsia, which is more of a sensory primary disorder.
Anita, someone is asking what test this is that's on the screen.
Oh, yes, it looks like the SNAP, exactly. It looks very much like
Somebody
it.
got it, yeah.
Yeah, good point, exactly. It could also be, and it's very also similar to the star cancellation as well. Yeah. And what about here? So we've got like a letter cancellation, and we've got a star cancellation test. Thanks, Rosalind. Yes. So which would be the more letter cancellation?
Someone is suggesting hemianopsia in my chat.
Okay, so how do you assess the disorganized scanning in the last frame? Oh, so are you referring to the previous slide, Susan?
Yes.
Okay.
Sorry, slow typer.
No, that's okay. So let me go back to the previous slide. So here, don't worry, Susan. So so basically here the scanning. So if you look with the the individual, if the individual is more so like the red arrows is really what they've done, like in terms of their scanning. I haven't really identified, but the red stars, the red lines are really identifying their search patterns going left to right and top to bottom. So it just shows a more organized search pattern. Whereas here, this is more of a bit of a disorganized search pattern that then helps you discriminate between USN and hemianopsia.
So were you watching their arm and what they were doing? And
yeah. So what's really critical with USN and hemianopsia when you want to discriminate is that you want to label which stars or which items that they're identifying first, and sort of the pattern that they're doing it.
okay.
There are these different clinical observations to make during the test.
Thank you.
So, so here, so what's happening here with this image is that if we look at the two, it's really both USN. So, with hemianopsia, you're going to really see that they really only identify items that are on the right side from the midline, and they wouldn't really go that far out. Whereas with USN, it is possible that they can see past that midline and just really neglect a part of the page, right? So that's why it would be more USN than hemianopsia, because if we look really at the midline, they're really passing that midline, and so that's why it's more USN. And same thing with this image here as well. Like this image here, if we look at using the midline with this arrow, it's really passing that midline, and so that's really typical of USN, where it's not that neat midline that they follow as in hemianopsia. So hopefully that clears up those questions. So just before we get on to the interdisciplinary roles, I'm just gonna double check with time. Any questions that you have? I know I went through a bit quickly on the visual perception, you know, because I figured it may be more of a refresher, but wanted to really kind of, you know, spend a bit more time on unilateral spatial neglect because of these different hemispaces and the different complexities that it has for in terms of assessment. But any questions that you have in regards to visual perception or USN or both, happy to answer them. If someone is moving from, okay, so we have Nadina, if someone is moving from lying to sit and they forget their left arm, is it more of a motor neglect or a personal space neglect? So that's a great question. So it's you know, it's more like motor neglect, you can really detect it more where you know, it's really through functional activities where you're going to start to discriminate between motor neglect and personal neglect. Personal neglect is, again, I would say, you know, if they're moving from lying to sit and they forget their left arm, I would say it'd be more of a personal neglect or personal space neglect where they're really, and this is something that you commonly see in someone with neglect, that they actually leave their arm behind or they forget to dress their arm because they're really ignoring that arm when they're moving in space. And which is why it becomes very dangerous for them. Motor neglect is them really, you know, not, you know, sort of upon command, you know, using that arm or integrating that arm in function, right, in a motor movement, or even, you know, like if there's, you know, where they're reflexively going to swing their arms when they're walking, that they don't swing that arm, that, you know, that left arm the way they would naturally in a walking movement, right? So and often when they're, you know, really forgetting their arm, or they're forgetting their arm is getting stuck in the wheel, in the spokes of their wheelchair, it's really that neglect of that personal space. And another way to really discriminate between the two is really, like I said, through ADLs, like in a bathing task, where you're really able to see that they actually don't pay attention or incorporate that that left hemispace on their body. Does that clarify, Claire? Oh, and Lori, go ahead. Yeah, you want to unmute?
Yes, sorry, I'm just trying to, I think I'm unmuted.
Great questions. Yeah.
Is it possible though to have like a combination of both though? You know what I'm saying? Like where it's kind of hard to tweak out, but obviously, you know, if you have someone with, you know, intact motor impairment, but decreased proprioception and decreased light touch, I just find it hard sometimes to differentiate, right? But I think in the end, it can be a combination, correct?
It can definitely be a combination. So you could have, now again, what's very distinct about motor neglect is that what we have to remember is that the motor function in that arm is completely intact, right? Their sensation is intact, right? And so now if the individual has how do you say, motor weakness, and you know, they have sensation issues and they're really forgetting their left arm, it's more likely that it's in this case it's going to be a US end of that personal space, right? Now, like I said, proprioception, when you're moving your arm in space, that proprioception usually it's really understanding your body in space without that visual input, right? Meaning like you can close your eyes and you could still imagine where your body is in space. Somebody with USN or personal neglect, if you move their arm, they're still not perceiving their arm, right? It's really their they've just not paid attention to it, right? So they haven't put, you know, their clothing on, for instance, they haven't dressed their left arm. They've dressed their right arm, but they haven't put the sleeve on their left arm at all, right? Or they haven't even brushed the hair on their left side of their head. So that's really the neglect of the personal space. Yeah.
Right, there's another question in the chat as well.
Yeah, and also just to clarify, what we can have happen is that neglect can be, you know, you could have a combination of these impairments. So you could have like say neglect of the near extrapersonal space, the personal space, and the far extrapersonal space. You can have sort of neglect of all these spaces in combination. Yeah. Yeah, go ahead in the chat. Oh, is it the
For
chat?
someone with motor neglect, can you move their arm if it is a self-directed movement?
Oh, so for someone with motor neglect, can you move their arm if it's a self-directed? Oh, sorry. Okay. Thank you for the
Can
clarification.
they move their arm? That's better.
If it's a self-directed movement, so meaning like, are they able to, like, if you ask them to, okay, so if they're moving it, if they're initiating that movement themselves, yes, so you will see that they're able to, if it's a self-directed, if they are initiating that movement themselves, they can do that. But if it's more upon command, or like in a movement where they would typically be moving their arm, that's where you see that they don't move it as much with motor neglect, even though they have full capacity to move that arm. So yes, and you'll see somebody with motor neglect, where like they're able to move their arm, sort of reflexively, like you said, or like in a self-directed manner. Exactly. So hopefully that answers Katie.
Yeah, I think she's good. She's got a thumbs
Yes,
up.
thank you.
Okay.
Yeah, it was just to distinguish that if they can move it on their own, and then it's when we ask them to move it that they can't. And you did clarify that. Thank you.
Exactly. It's that they can't. So that's where it becomes a bit confusing, because you're expecting them to have normal motor function. There are, you've tested them, in terms of strength, and so they have that motor function because you've seen them move their arm, but that they can't do that upon command. Yeah. Any other questions? Sounds good. Great. So in terms of interdisciplinary roles, and if you want to look at more roles specific to USN and visual perception management, this can really have a significant impact in terms of ADLs, as you can imagine, IADLs, all areas of function. And so, what we really need to think about is, really trying to engage all disciplines in really working together to address visual perception and USN in terms of really managing this condition and really understanding the kind of impacts that it could have on ADLs and how it can affect participation, and also providing this information to patients and their families, and just really having them up to speed and on the same page in terms of what the client is experiencing. So as you can imagine, somebody with neglect, it could be very confusing for both the patient and their family members. And so just, wanting to bring everybody on the same page in terms of what to expect and how we could really promote recovery with these clients. Really using evidence-based approaches. And so, of course, it really takes an interdisciplinary approach where, you've got OTs really involved in assessing and really discriminating the presence of visual perception impairment or a USN, in terms of providing them with appropriate treatment interventions, really looking at, what could be done for fall prevention, really communicating that this impairment exists with the team, as well with the patient and their family, and what we could do to really promote function in these clients. So, what could be different remedial approaches or compensatory or adaptive approaches that we could use to really either adapt or, promote like the client's independence in a way that's either adaptive or a way that really, works on their ability to scan the environment and really, treat that visual inattention that they have. So, we're going to talk about, I think on day 3, mainly about what those treatment interventions are, but it's really, a lot of OTs will really work on this area in terms of assessment and treatment. But however, it's also an area where PT can be, involved in terms of really looking at, being aware of their neglect and their potential for falls, and really incorporating visual scanning in their mobility treatment. So you'll see later on day 3, we talk about visual scanning treatments, and what we found in the literature is that whenever a client is working on mobility, when you work on mobility and visual spatial training at the same time, this really promotes function in both aspects. So you see improvements in mobility, but you also see improvements in visual scanning as well. So it's really good to sort of dual task and have clients working on both skills in treatment to really improve both mobility, but also improve their visual scanning skills. Again, PTs can also be involved in patient education in regards to this. Optometrists can be involved for visual field testing or visual acuity. The nurse as well could be involved in really managing in terms of fall risk and being aware of the client's potential for falls and their potential for injury with their neglected side. So that's something to keep in mind. That these clients are really at risk of falls during transfers, during ADLs as well, or during different tasks that they engage in. And also, they could really benefit from having appropriate setup for their ADLs to maximize their independence. So, making sure that either they're set up for their dressing tasks or their ADLs, their eating, their feeding. These could be different things that they could be set up for appropriately in order to really make sure that the client is able to that their food is presented either in the space that they can see, or that if we're working towards scanning, that you set you've set it sort of a just right challenge to really encourage scanning, but at the same time not place things that are really too far left so that the client can't really see objects that they need in their daily activities. Of course, for medication management could be very important as well, really making sure that the client is set up optimally to be able to visually see what they need to engage in. The orderlies or the PABs, again, could be very much involved in this as well in terms of transfers, really being on the right side of the client to really, support them. And so, being positioned as well on their left side and really encouraging the client to pay attention to their left side and really supporting their left side in terms of transfers. Would be very important, making sure that clients are positioned well as well. So positioning is very critical for clients with USN. And so making sure that they're properly positioned in the chair or in bed as well. So really using proper positioning techniques, both for their hemiparesis, but also for their neglect as well. And then finally, often depending on some sites, but there could be a neuropsychologist that's present that often also is involved in USN assessment. But again, there aren't many sites that have a neuropsychologist available to assess all patients. And so that's where we don't see, we may or may not have that individual to engage in terms of managing USN. Yeah, Sue, sorry, do you want to ask a question?
Yeah, I just wanted to add, there could be other people on your team that would be a part of this whole process. As a rec therapist in my background, I'd be bringing people out in the community or doing leisure with them and would be trying to implement strategies based on what the team has told me.
Absolutely.
And then the other thing I would like to highlight is a speech therapist, and maybe you could speak towards, I'm thinking about reading and what you've talked a little bit about that neglect and how they could fall into this interdisciplinary care as well.
Absolutely. So yeah, so if clients in terms of visual perception, exactly that, speech therapists could be definitely involved in terms of reading, and as you highlighted as well, recreational therapists could be involved in engaging clients in activities, but being mindful of the fact that they could have a presence of neglect or visual perception, or really informing them of the type of interventions that you're involving the client in, and that may possibly sort of spill into the recreational therapist activities that are being assigned and their interventions with the client as well. So yeah, so these these common goals that you have in terms of improving visual scanning or improving certain visual perceptual impairments, could sort of work to, could be implemented in a recreational therapist's intervention.
Mm-hmm. I'm thinking about the speech therapist, even meds management, and having to read about their meds, or I don't know, maybe you know more about how they could be involved in terms of this issue.
Yeah, so like just involving, I mean, it could be even in terms of testing, just so that they're aware of the neglect, or aware of, where does the neglect occur and in which hemispace, and how that could affect reading could be, important information for the speech therapist to have, and, to really, or even to promote their testing so that things are placed in the hemispace that they're able. right? So that they could have more accurate testing of their assessments that often involve a lot of reading, right, of tests.
Yeah, thank you.
So that's definitely, and this is definitely, communication is really important across the health professionals in regards to these aspects. I'm just going on the next slide. So in terms of guidelines for visual perception assessment and treatment, what we see in the best practice guidelines is that clients have been, so all patients with a stroke diagnosis, it's been recommended in the best practice guidelines that they should all be screened for cognition and perceptual impairment using a validated screening tool prior to either leaving the emergency department or a primary care setting. So this has been strongly recommended in terms of cognitive screening, which includes visual perceptual assessment or function and USN. It's been recommended that clients are screened within 48 hours of admission to a hospital. So there's strong recommendations that clients are assessed really in that early phase post-stroke within that 48-hour period for any visual perceptual function and USN. Primarily because of the fact that they are at risk of falls and that early interventions could be offered to these clients and it could lead to better outcomes. Finally, as well, like those with cognitive impairment should also receive, or those that are screened with visual perceptual or USN, the presence of USN or visual perception through a screening test should also receive additional assessments. So meaning that we don't really stop at the screening and that we need to move forward and think of what could be assessment tools that really could then really detect the extent of the impairment, really, like how severe do we have, how severe is the neglect, and really documenting that so that we can appropriately then provide treatments and really document at that point, how much improvement can we see over time. So those assessment tools will really help us see and document and see those improvements over time. So we'll really, in our next day 2 series of this workshop, we'll look at, really what are the screening tools available out there to really detect the presence of these impairments, and what are the assessment tools that we have that can really look at the extent of the deficit and the extent of the impairment that we see, and how severe is it in the client, right? So that's what we would see with the assessment tool. So these are the screening tools that we have that have been recommended in terms of stroke best practice guidelines. So the screening tool to really detect the presence or absence of USN is the line bisection test. The screening tool really to detect the presence of, this is more for like cognitive impairment. And if you think, if we look at the MOCA carefully, it has one little component that looks at perception where they have to really copy a figure. So that could be used as an indicator to some issues of perception. So we have the MOCA that's more commonly used now, and that's been recommended in terms of best practice guidelines as opposed to the MMSE or the mini mental status exam. And so for a stroke population, it's been recommended to use the MOCA, but it has a very specific item that looks at perception that kind of gives us an inkling that we might need to follow with other assessments. And then in terms of assessment tools, to really look at the extent of visual perception and USN, so really looking at it and then the extent of this impairment, we have the MVPT, as well as the BIT, the behavioral inattention test that looks at USN. So we've got those 2 tools that we will look at in more detail at day 2. So just looking at the gaps, so what we've seen clinically, and this is where I'm hoping to have a bit more discussion and sort of feedback from you, is where we see gaps in clinical practice. And so this is a study, it's done quite a while ago. It was done during my master's work, where I wanted to explore, how often are we really looking for assessing USN or visual perception. And so there were both urban and rural hospitals that were surveyed, that were not surveyed, but rather chart audits that were done in these centers, acute care centers. And so we wanted to see how often did clients who were admitted with a diagnosis of a stroke, did they receive any type of USN or visual perception assessment? And so 38% were actually received either USN or visual perception assessment. And then only 13% actually received a standardized assessment of USN or visual perception. And then when it was a USN standardized tool, only 1%. And then finally, within that 48-hour period, as per best practices, 3% received either a USN or visual perceptual standardized assessment within that 48-hour period. So really, you know, there was a serious gap in terms of assessment. And then when we wanted to see what happened, what was the picture in terms of inpatient rehab, a different study was done across Canada where clinicians received a case study of a typical client from a stroke rehab center, and there were very clear cues as to you know, certain indicators that could indicate the presence of USN. And so we wanted to see whether therapists were able to identify with these clinical cues the presence of USN and whether they followed up with an assessment and treatment intervention. And so what we found was that in rehabilitation, there was actually good news. So 80% of clinicians, and so this study actually was done a year later, where 80% actually identified USN as a problem when prompted with this case study. And unfortunately, though, it didn't, you know, not as many followed up with assessments or more formal assessments of USN. And then did not, you know, only a little over half actually offered a USN treatment. So, you know, visual perceptual scanning, limb activation, where they're actually activating the limb to get them to move the limb in space. Eye patching was done. And so we'll talk about those treatment interventions in day 3. And then, of course, 16% sort of received best practice where they saw that, you know, they read the case study, they identified USN as a potential problem, they followed up with a standardized USN assessment tool, and they provided a treatment intervention. So 16% of that sample of 253 OTs actually provided that best practice approach. And then finally, what we see is these are just lists of barriers and facilitators that were documented in the literature in terms of what therapists perceived as sort of barriers or facilitators to managing USN and visual perception. And so these are some of the indicators or factors that they felt, you know, that they found. And I don't want to read through all of them, but you know, I just wanted to, you know, leave them here for you. And I was hoping to sort of open the floor for discussion as to, you know, do any of these barriers or facilitators, or even the gaps that I had mentioned earlier, do any of these resonate with your center, or do any of these barriers, are these barriers that you've perceived in your center in terms of trying to adopt best practices for either visual perception or USN management? So any thoughts about that? So do any of these factors resonate with you? Just to mention, you know, some of these barriers and facilitators were some that were identified in a qualitative study that was done with OTs, you know, when they were asked more qualitatively as to, you know, how do they manage USN post-stroke, and, you know, what were certain barriers and facilitators that they perceived. And so that was done in 2014. So just wanting to hear from you guys of, you know, do any of these, do you feel that these could be potential factors in your setting? So I think Nadine has shared time could be definitely a barrier in acute care. Yeah. Difficult to definitely use a full assessment like the MOCA. Yeah, absolutely. So time was indicated as a huge barrier. Time, you know, to really administer these tools, but especially for treatment. Yeah. So Susan's talking about the fact that absolutely sometimes clients are really difficult to assess. So it's really hard to, you know, really find sort of in fact, depending on their impairments, depending on, you know, the presence of a language impairment, that could be a limiting factor. There could be multiple factors that really explain why, like, some tools may not be appropriate or adequately suited for certain clients. So Emily, you're asking if the recommendation to screen is within 48 hours, would you use the screening tools while the patient is in bed? So yeah, so the recommendation with that 48 hours is that the patient needs to be admitted to an acute care setting, and they need to be they need to be at least alert at that point. So they need to be, able to, actually perform that as screening tool. So they need to be alert enough to be able to do that, or considered at least medically stable. So if it's not able to be done, within that 48-hour period, as soon as possible is the idea. The idea is that, you definitely want to be offering a screening tool of visual perception or USN to clients before discharge. Is really ideal, and as early as possible, as soon as they're medically stable, would be, sort of the best practice. So in home care, I would say the three barriers are lack of time, knowledge gaps, QI requirements. Yeah, definitely. If they're coming home, we may not know what was already done in hospital and risk retesting something that they want. Yeah, exactly. So, often that sort of communication across the team in terms of what's been already assessed is really critical. To really knowing what had been done already in hospital, and just avoiding that sort of the duplication, right, of work. Yeah. And maybe like understanding which screening tools to use and which situations would be important. Any other thoughts or?
Nita, can I ask a question about your research? And,
Yeah.
When you posted those numbers,
Yes.
seemed quite low, right? And it was from 2006. I wonder what best practice said back in the day then, and if you tested that now, if there would be a much higher percentage. Like I think of our hospital and the testing that they do on rehab, I think would reflect better in these numbers today than they would 20 years ago.
Absolutely, and that's a really good point. So the timeline in terms of when this testing or when this study had taken place was really, as the Canadian Stroke Network had really got together with their researchers across and their clinicians across the country to really develop a coordinated stroke strategy across Canada. And so this test was done really prior to that, where they were working together to really develop those guidelines. And so that's sort of at that time, that's kind of when I pursued my master's work, and I was really interested in neglect in general. And so wanting to know about, how often or how systematically is this being assessed? And so, because what had happened was internationally, USN and visual perception were being recommended to assess. When we looked at the guidelines in the UK, USN and visual perception were included as part of their assessment, and it was being recommended there that it would be assessed within 48 hours. And so, when we looked at what was being done internationally, that helped inform the Canadian guidelines. And that was when they really inserted guidelines specific to visual perception in USN, recognizing that it was an important impairment to assess. And then we saw that there was a really a serious gap. Now, with the coordinated stroke strategy in place, with the implementation of that, lots have been done. There were modules that were developed on Stroke Engine, which is a great resource. Nicole Korner-Botensky to really summarize a lot of the assessment tools out there. And I don't know, hopefully some of you are familiar with that tool, the website, but really summarizes information in a way that's easy to apply and hopefully in clinical practice. And so that really helped move things along in terms of continuing education and knowledge translation of this information. And so I foresee that, again, the test has not, the study has not been replicated, but I foresee the numbers being much higher now more than before. My role now currently though is less in research and more in teaching, and so I unfortunately haven't got a chance to continue that line of work, but we've definitely seen improvement in terms of or can expect to see improvements in terms of assessment. A lot of the studies that were done looking at when they had to roll out the coordinated stroke strategy across Canada and roll out those best practices. And they did some testing to see, did it get implemented in the different sites across Canada? There was some success that was documented in those studies that, you know, a lot of the guidelines were being implemented. So again, I really anticipate that those numbers will be much higher now.
Thank you.
Yeah, thank you. Any other questions about neglect, visual perception, or even just what we see in terms of gaps, or any thoughts of what you've experienced in clinical practice in terms of USN or visual perception? Oh, hi, Kristen. Yes, thank you.
Hi, I'm just appreciating all of this. It's kind of new for me. I'm in primary care. So I saw that one comment that they're hoping for testing in a timely fashion. Can you describe a scenario where primary care might actually be able to help? Because we would love to. We see all kinds of stuff as the patient sort of navigates post-hospital and back into home life.
Yeah, so really understanding, like in terms of assessment and treatment, or
Yeah, just any role. I mean, we do MOCAs all the time for, if somebody's had delirium, if somebody's had, and we time those accordingly, but we don't really have anything for stroke. And I one comment was we don't really know what was done in the hospital, and that it's true. We rarely see those reports. So I could maybe try to find out if they were done. I don't know.
Yeah, like, so, given that there's a perceptual component in the MOCA, I mean, that could give you, just clinically when we observe clients completing the MOCA, which is why, I had included in the slide, is that it can give us a sort of indicator as to there could be a perceptual issue that the client has, right? And if we don't have information from their discharge, right, the discharge summary from from wherever they came from prior to being in the community, as to what was done in terms of assessment, or what were the what resolved and what didn't resolve, right, once they've been discharged. If we don't have that information, again, from the MOCA, you could get, sort of bits and pieces of information in terms of perception that will then hopefully, encourage other, further assessment. And so that's when we would recommend, either if it's a suspected USN, using more of a line bisection test, which is a quick and easy tool that we would cover on day 2, that can be used to just document the presence of neglect. And then finally, the other tool would be the MVPT. If it's more specifically a visual perceptual deficit, it might be interesting to really complete the MVPT to really screen to see how impaired they are. I do recognize that the MVPT takes quite long, and that could be it's sort of, I know time is very an important factor for community care, but those are the sort of, in terms of visual perception, that's really sort of been the gold standard that's been recommended.
Yeah, thank you. Okay, looking forward to it.
Thank you. I see there may be another question in home. Oh no, I think
I think we're good. I stopped sharing because your screen was down, and the timing is perfect. It's 12:57. I don't know if you want to put your last slide up with your email address.
Yeah, absolutely. So I'll do that.
I just would like to remind people that are in a group to type the names within their group in the chat for us. So North Bay Regional Health Center, we'd like to know who's at that site watching today, so we can make sure you get your certificate. I sent out the link to the handouts for day 2 on Monday, so you should have that. You should have the Zoom link for day 2, which is different than today, and you should have all the handouts. Anita has done a PDF of her slides, but as well, she sent, I don't know, 8 PDFs of different assessments and screens and things that we'll be using in breakout rooms. So just let me know if you weren't able to access them so I can make sure you get them. Make sure you have the link for Thursday at 11.
Yeah.
Anita, anything else?
Oh, that's pretty much it. Thank you very much for your wonderful questions. Very interesting conversations this morning. And I wish you all a wonderful afternoon and look forward to seeing you on day 2 for assessment and then day 3 for treatment. So again, any questions that you have or any learning objectives that you feel you'd like to have addressed in the next coming 2 days, please send me an email and I'm happy to address them. And if not, I wish you a great afternoon.
Great, thank you.